My use of this really is as part of a laser lead extraction procedure. Lead extraction, of course, is a growing business. Unfortunately, there's more and more leads, and infection happens, and patients are getting older and sicker. So we do have a large volume. Oh, great. And I've got backup here. Dr. Wool is my backup in the cath lab, and laser lead extraction requires backup. We always need backup. Actually, that's the the most important part of all these procedures. So we have a growing volume of hardware in the heart, and of course that in our patient populations that also means a growing population of infected hardware in the heart. So the patient that I'm going to talk about is a 7-year-old gentleman with old pacemaker leads and the abandoned pacemaker leads and additional pacemaker leads placed in 2018, who came in with really feeling very sick for several months and had been really simmering with sepsis for a few months. Came in very severely thrombocytopenic with platelets in the 20s and renal failure, and had this on his tricuspid valve attached to leaflets. And this is really unfortunately not all that rare. I mean, when people have vegetations, sometimes they're really small, but and they're tiny. But we do see quite a few of these, and there's really a question what to do. This is well over 2 centimeter vegetation, and the guidelines and the standard of care in most places is to send this patient for surgery. But a patient like this with his comorbidities was really going to be very high risk for surgical resection of that. And so this patient had a lot of leads. There were 2 ventricular leads, and the vegetation was attached to one of those. So we came up with the plan of removing the vegetation with the angiovac system at the time of laser lead extraction. This is another element where I think people in this room sometimes do the lead extraction, and then if needed, if enough vegetation material goes to the lungs, then they'll extract or suction out the material from the lungs, versus some people prefer to do it right at the time and right before removing the leads. And there's no real data to say what's right or wrong. The angiovac system is a 22 French funnel-tipped suction cannula. One of the types of it has a 180-degree bendability to it, and so you can introduce it through a 26 French gore dry seal sheath in either a femoral or IJ approach. And you have to have a venous return or an arterial return through a 16 to 18 French sheath. And there's a filter to pick up the collected vegetations, and this is done on anticoagulation. And so the angiovac looks sort of like this coming from below. It's manipulatable. You can steer it to some degree. It does have the reach in general to reach the tricuspid valve from the femoral approach. It's a little bit easier to get into the ventricle from the IJ in some cases. And in general, we can manipulate it usually using a lot of TEE or intracardiac echocardiography guidance towards the vegetation. And over here, you can see it manipulating the lead and actually grabbing onto the vegetation. Once the vegetation is grabbed, usually this sheath is sucking blood at 3 to 3.5 liters per minute. But once you've glommed onto the vegetation, that suction, the flow stops. And so if you're lucky, the vegetation just immediately aspirates into the filter. But if it doesn't, if it's big enough, then chattering the suction with a clamp, closing and clamping and unclamping will help break it apart. And the suction is powerful enough that in general, we really don't see too much embolization of pieces so much. It's quite a large amount of flow. So when we did that, we collect quite a bit of debris. At the end of the procedure, you can take all this out of the filters, and in general, it usually amounts to quite a bit larger mass than what you would have estimated from the TE images. It's just always more bulk than you would ever really want to shower to the pulmonary artery. And then, of course, we have to remove the leads. So for this, we reverse the heparin and we, or we leave them on heparin and just let it simmer down. And lead extraction, I won't really talk about, but it is a bear sometimes, and it was in this case. In this case, as in many cases, sometimes the leads, as we start removing them, some of them come out and some of them, don't. In this case, one of the leads really was quite damaged when it was abandoned many years ago, and we couldn't get a stylet into it. And the problem with that is that the leads tend to break when you pull on them, or they don't provide enough support for us to safely advance a mechanical sheath or laser down to the IVC. So to make it safer, we usually, as over here, we snare it from below, we pull down on it, and that allows us to increase the safety of advancing a mechanical sheath or a laser sheath down as seen over here. Here we were able to get the laser sheath down to the IVC level where it's snared, but the lead still wound up breaking. And so the fragment that was left behind is disturbingly large. It was still crossing the valve. And however, we had removed the bulk of the vegetations. We had preserved the tricuspid valve. We'd not damaged it. There was a hope that that would be enough. It wasn't. The patient still had persistent sepsis, and so when the patient's condition was a little bit better, a few weeks later, basically, we snared the remainder of that lead from above, and then we were not able to remove all of it. That little tip broke off. That happens with very old leads sometimes. But that part of the lead is mostly not in contact with blood. And so generally we find that people can clear infections with that. And the patient did, as you see over here, get a leadless pacemaker. So that concludes my slides. I'll end this by just saying that the data for this procedure is very limited. The published data essentially is a 88 patient systematic review of the literature. So unlike the great debates we had earlier today, this is a procedure that we are doing, and we're sort of making judgment calls more than basing the data based on outcome. So I'm hoping that with a few more years we'll have a little bit better data on this, but that's my case.